Is it Mrs. John?
It is, yes.
Hello there, my name's Geordie Morell, I'm one of the doctors on the ward. I've been looking after your husband, and I believe we wanted to give you a bit of an update of what's been happening. So first of all, just to clarify, because obviously there's confidentiality issues and your husband's not here at the moment, so I did have a quick chat with him and he was quite happy for me to let you know everything you want to know, basically.
Right, okay.
Is there anyone else around who'd like to be with you?
No.
Okay, fine.
Fine.
So just let me know what you know so far about what's been happening.
Well, he's had this cough and breathlessness for ages, and he wouldn't go to the doctor because I said so. It was when it started affecting his golf.
Right. You're keen golfer, is he?
He had to do something about it, yeah.
Okay. And often things go through people's heads as to what might be causing it, what the underlying problem might be. Anything you've been worried about?
Well, the silly man won't give up smoking, so I suppose I've tended to think the obvious, but we haven't discussed it.
Okay. And just to clarify, by the obvious, you mean?
Well, I mean, I think he's got lung cancer.
Okay.
I don't know what he thinks.
Okay. And have you had any experience of cancer, particularly lung cancer?
Not lung cancer. I mean, I had experience of cancer with one of my parents. But,
Okay. And what happened with them?
Well, at first they were all right, and then it came back and she died.
Right, I'm sorry.
Do you want to tell me that it
Okay,
is?
well...
I feel it is, I can't think.
Right, well, the evidence I've got would suggest that it is a type of cancer. Okay. I'll go through what
Silly man.
Sorry. Yeah. Well, we see a lot of people smoking. Some people are lucky and don't have any problems, and some people not. But it's...
I mean, he says he smokes 20 a day, but I don't think he does by the evidence of cigarette packets.
Well...
So I think it's probably nearer 30 a day.
People do tend to
underestimate
their own cigarette use, but it is...
I mean, on one level I'm shocked, obviously, because we've got it confirmed, but
yeah.
I can't say that I'm surprised.
Okay. Now...
what's going to happen next?
Okay. Well, what we've found, the reason that he's so breathless with this is that there's some fluid build up in the lung, and that's how we first found out that it might be a cancer.
And can you do something about that?
Well, we can. There's various options for managing that, and I'm going to be talking to the specialists now that I know what's happening, and see what treatment options are available. There's all sorts of things that they offer.
Are you not a specialist?
I'm one of the lung specialists. I'm talking about the cancer treatment specialists. So what we tend to do is have these meetings where we have a input from all of the various big brains, if you like, and I don't count myself amongst their number. But the cancer specialists, the X-ray specialists, and there's also then we have input from various other groups who are used to looking after people with cancer.
From the test you've done already,
yes.
I mean, how bad do you think it is?
Well, I'll tell you what we know. There's the plain X-ray of the chest showed that there was a build-up of fluid, and that would certainly explain why he's been breathless. We've then taken a sample of that fluid just by passing a small needle into the chest and drawing off some fluid, and that when they looked at it under the microscope, they found that there were cancer type cells in the fluid. So that obviously sets our alarm bells ringing, and then we've looked a bit more further. We've done a CT scan. Have you heard of those?
I get them mixed up, which one you go in a tube and...
This is the one not in the tube. This is the big donut-shaped scanner.
Yeah.
And it uses X-rays, but it gives us a sort of a more three-dimensional picture of the chest. And that does show unfortunately there's spread of the cancer to the liver. Okay. They've also...
So if it's gone to the liver, there's...
Well, that makes it more serious. It does depend on what type of cancer, and that's why I'm involving the cancer treatment specialists.
But you probably can't do very much for him.
It means that doing an operation to cut out a tumour wouldn't cure the cancer. But,
you know, most people who aren't doctors tend to say that if it goes to the liver, that's the end.
there are certain types of cancer which will respond to medication treatment, so chemotherapy. And in those situations, it's possible that not only does that treat the primary tumour, the one in the lung, but it can also treat secondary tumours as well. But that's why I want to involve the cancer specialists. They're much better at knowing what's going to work and what's worth trying.
I think you're not going to know the answer to this, but when's he likely to come home?
You're right, I don't know the answer for sure. I want to get him home as soon as possible, but I want to make sure that we've completed all of the tests and treatments that we need him in hospital for. A lot of this treatment can be done if, for example, people have chemotherapy or radiotherapy, which are the two main non-surgery treatments for cancer. Those can be done on a sort of an outpatient basis, so people come in to the cancer treatment centre, have their treatment, and then go home from there. Now,
if it's gone to his liver, he probably hasn't got very long, has he?
Again, I don't have a crystal ball to tell you exactly what's going to happen. I don't think it's a bad idea to be... I like people to be prepared for the worst, but I still think there's room to hope for the best. Okay.
What if when he comes home, am I going to get any help with him? Because who'll help? I'm just not certain I can manage this up to the end, and I know he'd want to be at home.
If we are looking at, his sort of last weeks and months of life, there is lots and lots of help available. Okay, so you're not alone here. Is anyone at home with the two of you? No. So there's all sorts of agencies that we call upon that are essentially waiting for people like your husband to come and give it all the help they can. So Macmillan is probably the most well known of those, but there's so we work very closely with the Macmillan team, and they're under the sort of umbrella in the hospital of palliative care. And palliative is symptom relief. So I've heard of them, and that they're very good. But I was thinking more when it gets towards the end. Yeah. I'm not sure I'll manage the nursing care and everything. That's the sort of thing that they can help you with. Now, it really comes down to what the patient and their family want in terms of help. People are sometimes unprepared for when it comes to the end of someone's life, how much looking after they need. And
I guess I jumped to that stage because I nursed my mother when she had cancer. And
I don't think
and I just know that the end was bad, really bad, and I know he won't want to come in hospital. And I'm older now, I'm not sure of my capabilities on this.
Well, there's a possibility that if you wanted him at home, when we feel the end's coming, I say we're very much not there yet, but I think it's not being too cruel or pragmatic to think about the end.
Well, I feel it is in a way,
No,
but it's because of previous experience.
Yeah, that's fine.
And, you know, I've got an idea what might happen.
Yeah, and I think it's being prepared for that. I think that's always going to be a good idea. It may be that we're not facing that for years, but I think knowing.
I think you might have that one.
As I say, I don't have a crystal ball.
Well, that's
I don't know.
2 minutes remaining.
I don't know, and that's why I want to. We'll have this meeting with all of the big brains, and they'll give us some more information. I've just got the very sort of beginnings of the story here. Okay,
Right.
and I think it's no harm, like a detective novel. We can skip to the end and look at what might happen there, but you know, we've potentially got a long story before that.
Well, I wouldn't say all this to anybody but you, because it sounds absolutely dreadful, but as I say, having had previous experience, it scares me to death.
I can imagine it would, and I think sometimes knowing what might happen makes things less scary, but sometimes having had a bad experience can make it worse.
Yeah.
But rest assured, I've looked after many people entering their end stages of life with a variety of illnesses, and I know that the Macmillan team and the various resources they call upon mean that on the whole I've seen a lot of people die peacefully in the place where they wanted to die, and for some people that's in hospital. For many people, they prefer that to be their own home, or the sort of the halfway house, which we've not really mentioned, is hospice, where they provide a lot of the comforts of hospital, but with a lot of the comforts of home as well. So there's scope there, but I stress at the moment we're just sort of.
I'll try not to think about it yet.
Okay. Anything you'd like to ask me?
No, there's not really anything till they've seen these people, as the, you know.
And we'll let you know
a bit more, yeah.
when we've got the word from them, and
Okay.
we'll have a better idea of how things are going to go.
Right. He knows this.
I've talked to him and
Right.
I told him that.
Yeah. I think he probably like me and you anyway, but we just skirted round the issue and decided it was bronchitis.
Okay, we'll stop it there. Just
Thank you.
Okay, Dr. Morell. So you've spoken to Mrs. John, who's
That's
Mr.
right.
John's wife.
Yeah.
Do we know why Mr. John wasn't present? Did you establish?
I didn't establish that, no.
No. And how do you think, or how would you establish that if you'd run a game? What do you think you should have done at the start?
I think just asked
To clarify.
with the subject, Mrs. John.
And I think at the end, you certainly dealt with the fact that he knew about his diagnosis, and I think you dealt with initially the confidentiality issues, saying that you spoke to Mr. John and you got permission.
Yeah.
So that was clear from the start. But
Yes.
I just think if you'd have established why he wasn't present,
No.
and possibly what. She spoke, you know, he'd told her.
Yes.
Now, prognosis-wise, always difficult.
Yeah.
It's difficult in everyday practice, certainly. Just tell me, and you certainly demonstrated it very well, but just tell me, you know, she wanted to know the prognosis and what was going through your mind and how you dealt with it.
So I don't know. I don't know for sure what the prognosis would be in small cell lung cancer with metastatic spread. I know, and she knew too that was a poor prognostic sign.
Yeah.
And in practical terms, I would always discuss these cases with oncology and get some information about what was possible and what was sort of possible in terms of palliation, or if there was in fact treatment available.
Yeah, but I suppose just and certainly speaking to the experts and getting their opinions good, you often don't have that initially, as you eloquently told her that they were sort of more important people.
Yes.
Sure, you are very important, but Just you mentioned some of the terms you used, and you didn't give her an exact prognosis, obviously, because
No.
you didn't have that knowledge. But just what kind of things are going through your mind when you're trying to tell her, and some of the terms that you would use when maybe not being totally au fait with exactly the prognosis. What kind of things go through your mind, and what are good things to say to patients, if you like?
Well, I think
Or relatives.
I think the thing to avoid is being overly pessimistic and overly unrealistically optimistic.
Yeah.
And I think you have to thread a fine line between people essentially losing all hope. And I'd say that's more important with the patient than necessarily their relatives, but it's still important.
Yes.
And then being completely blasé about it and giving them an unrealistic expectations of that things are going to go perfectly well.
Yeah.
So I use the term a lot of that I want patients and their relatives to be prepared for the worst, but to still be hopeful for the best.
Yeah,
and I tend to paint a bleaker picture than I need to, not necessarily in this particular scenario, but in order that people, if anything, are pleasantly surprised by, to actually to lower their expectations sufficiently. I think giving people people like to have definite numbers, and they like to know you have this percentage, or you have this many years, this many months to live, and I think whereas that's helpful to them, and I know that in the long term it's unlikely I'm going to be sued for saying that they had 5 months when they only lived 4, or having 5 months and they lived 7. But I don't like to tell them information which I'm not confident accurate myself.
If you perhaps you've looked up the literature beforehand, because you know this patient's coming, and you know those figures, and you're asked those figures, how would you deal with that? Would you tell them the figures, and do you think it's right to?
I think as long as it's couched in terms of this is what the literature says, but that within that's an average, and make it clear that there were people who lived, in order to get that average, people who lived much longer, and people who lived a lot less than that prediction. So as long as it's couched in those terms, then I would tell them the facts and figures, but it's difficult to know what, in this sort of scenario, what facts and what information is actually going to be retained, and people will often pick on a particular thing and remember that. It's sometimes, with more time, it's useful, particularly if I'm giving that sort of information, that people repeat it back to me, so I know what they've understood, and it's an opportunity then to correct any misconceptions.
And do you think people they might ask the question, but do you think they always want to know?
No, I think sometimes it's a difficult thing that someone has the right, particularly the patient, in this particular case, who wasn't here, has the right to not know. And that's a difficult thing to take a sort of informed consent for, because how do you inform them of something which you can't tell them what it is? So it's difficult for them to have given informed consent that I don't want to know that information, or I only want to know if it's good news. And how reassuring is it for the doctor to go, all right then, and walk away? And I think that's quite a difficult scenario in the sort of a Breaking Bad news setting. And I think certainly people, from my experience, do ask about prognosis, and sometimes it's difficult if the patient's there, the family are there, and it's often the family who ask, and I think it is difficult, and certainly clarifying, do they really want to know the prognosis, and if the patient's present, do they want to know? Do they want us to discuss it with their family in the presence of the patient? And often a few questions, just exploring, do they really want to know the prognosis? Do they really want to know numbers, if that's what they're asking for? Before giving the information, I think is very good. And often they'll say, well, we're not sure, or we don't actually, want specifics. Although the first thing is, how long do I have to wait a doctor? And it's often, if you explore it, they don't
they don't want that
right.
specific questions, which, as you say, is an estimate.
Yes.
Yeah, rather than specifics. Good. I think certainly, all in all, there are so many good points to mention that we would take all day. I just think, again, getting the background knowledge of what the person knows about the condition
Yes.
you're about to talk about, and again, you very nicely spent a long time finding that out and finding their experiences out, not just my uncle or whoever's got cancer, what was their experience of cancer,
Yeah.
and dealing with that empathetically, and then saying, well, some people do have bad experiences, but not everyone. I think that was done excellently. Very simple terms used, donut-shaped scanners, and very clear and very layman terms used. Excellent, yeah. Well done.
Thank you.